Hello everyone, my name is Petra Sólymos, and my PhD title is Investigating Radioembolization as an Option in the Treatment of Liver Tumors. I'm a PhD student and a radiology clinician at the Medical Imaging Center. My supervisor is Dana Sorvati, and my scientific methodology supervisor is John Erturan. I would like to prolong the life of the patients with liver tumors, and I want to achieve that goal by radioembolization as a treatment. Therefore, I would like to determine the efficacy and the safety of the isotopes in the clinical use. I have two ongoing projects right now. My first project is about the safety and the efficacy of holmium radioembolization in patients with liver tumors. This is going to be a systematic review and meta-analysis. Liver tumors are a global health problem. However, only 30 to 50% of these tumors are suitable for definitive therapies like resection or surgery. Therefore, there is a need for locoregional treatments. Locoregional treatment options are ablation, transarterial chemoembolization, and transarterial radioembolization. And according to guidelines, there are scenarios when radioembolization is the best option because it can be potentially curative. Radioembolization has two isotopes in the clinical use, yttrium and holmium. As you can see in the table, these isotopes have different characteristics. Holmium is a newer isotope and has some advantageous properties that yttrium does not have. Holmium is suitable for SPECT and MRI imaging. As you can see in the picture, picture B shows us how holmium looks like in a SPECT image, and you can see how it looks like in an MRI image in picture C and D. This is good for us because we can perform dosimetry, we can calculate the intrahepatic distribution, and we can evaluate the tumor response based on these images. Also, holmium can be used as a scout, and it has a superior predictive value for intrahepatic distribution and dosimetry. For those who are not familiar with the word scout, scout is a lower dose of the isotope that we use for planning the treatment a week before the actual radioembolization with the therapeutic dose of the isotope. There is much evidence about the safety and the efficacy of yttrium for the radioembolization of liver tumors, but still evidence on using holmium for this purpose needs to be more comprehensive. Also, there are no comparative studies or RCTs that compare yttrium to holmium. Therefore, the efficacy and the safety of holmium for the radioembolization of liver tumors needs more summarization and contextualization. Thus, our aim is to define the efficacy and the safety of holmium transarterial radioembolization. Our clinical question is that in patients with liver tumor, is transarterial radioembolization using holmium isotope a safe and efficient way of transarterial treatment? Our framework is a PO. Our population is patients with primary or secondary liver tumors undergoing radioembolization. Our exposure is radioembolization using holmium isotopes, and our outcome is tumor response rate, overall survival, and toxicity. The hypothesis is that holmium TARE is a safe and effective way of transarterial treatments. Our clinical implication is to clarify and contextualize the clinical experience in TARE, because if we knew that holmium TARE is safe and effective, we could investigate if it's more or less effective in certain tumor types or in certain populations than yttrium. Here you can see the data about my systematic search. We conducted the search in five databases, and you can see the number of hits we've got. Lower, then you can see my search key. It has 3 domains. The first domain is about the population. It's the synonym of the liver tumors. The second domain is about radioembolization, and the third is about holmium. Here you can see my key articles, and next to them the reported outcomes, and I highlighted the outcomes that are common in all those articles. Here you can see the flowchart of my selection. Now we finished the full text selection, and we've got 20 eligible full text plus 2 ongoing trials, which we will come back when it's published. Yeah. So here you can see my progress of my first project. Now, currently, we are doing the data extraction. We've started it on the 30th of November, and it's 20% finished. My second study is about comparing the use of holmium and yttrium isotope in transarterial radioembolization for the treatment of liver tumors, and this is going to be on RCT. Okay, so as I mentioned, transarterial radioembolization is a type of regional treatment options for treating liver tumors, and has two isotopes in the clinical use, yttrium and holmium. These have different characteristics, but their efficacy on different tumor types and different populations are not yet fully understood. So our aim is to determine if holmium has different efficacy and safety than yttrium. Here you can see my clinical question and my framework. The clinical question is that is radioembolization using holmium isotopes at least as safe and efficient as radioembolization using yttrium isotopes in the treatment of liver tumors? Our population is patients with primary or secondary liver tumors eligible for radioembolization. Our intervention is holmium radioembolization. Our control group is yttrium radioembolization, and our outcomes are tumor response rate, survival rate, toxicity, and quality of life. We hypothesize that holmium TARE is at least as safe and efficient as yttrium TARE. And our clinical implication is that we knew that holmium TARE is at least as safe and efficient as yttrium TARE. We could explore whether it has different efficacy and safety on different tumor types and different populations. And this is important to us because it would allow us to use the isotope that has the best potential therapeutic benefit for a given tumor type. In summary, I have 2 ongoing projects right now, and I would like to finish them until the August 2024. I would like to finish my presentation with a quote: "Man can learn nothing except by going from the known to the unknown." And thank you for your attention.
First of all, congratulations on your presentation. It was very interesting. Actually, my question belongs to both of your projects. You mentioned in both outcomes that you're looking into tumor response rate and toxicity. How do you plan to measure these exactly? Because I'm not really familiar with this. Thank you.
Thank you for your question. Tumor response rate is commonly assessed by using CT or MRI images, and toxicity is evaluated by the reported adverse events. And there are standardized criteria for both of them. For the tumor response rate is the RECIST criteria, and for the toxicity is the CTCAE criteria system, and these are ensure the consistency across the studies. So this is how I want to measure this.
Thank you so much.
Thank you.
I have a comment. You started your vision that you want to prolong the life of patients with liver tumor. I mean, is that true? Having a liver tumor is not a funny thing. We can agree on that. And these patients die in a very nasty condition. So how would you decide that in that patient it's worthwhile doing this radioembolization, but that this is now too late and it would be medically futile to do that?
Thank you for your question. So there are
My pleasure.
There is some criteria that needs to be true for radioembolization, like the patient has to have solid tumors, single nodules of tumors, bigger than 2 centimeters but less than 8 centimeters, maximum 2 nodules, and these type of things maybe. So not eligible for ablation, but eligible for radioembolization. So there's a gap between you can't ablate a person, but you don't want to just don't want to give just palliative therapy. You give a radioembolization to them.
And what is actually the benefit that they are achieving from this treatment?
Yeah, so we can prolong the time they have, so they can actually achieve a transplantation, for example, and if not, then we give them a couple of more months.
Just to carry on with the question of Joe, that does it hold through all kind of histopathology results? I mean that Is there a difference between a hepatocellular or a cholangiocellular carcinoma?
Yes, there is a difference, but in this scenario, there is not. So for the criteria for radioembolization is the same with cholangiocellular.
It's the same, okay.
Yeah.
Can I just ask again, congratulations, and I don't know if I got it right. So for the holmium, you need to have MRI or SPECT, right? It was shown there.
Yes.
Okay, and I'm just thinking about the accessibility, because as I know, like for MRI, you need to wait, like there is long list, and also SPECT is not accessible everywhere, and the cost as well. Like if you can think like how you are gonna figure this out in your project. Thank you.
Thank you for your question. This is quite a new therapeutic thing, holmium. So we don't have a lot of cases. We had like 17 cases last year with holmium, so we can make them get into the MRI and the SPECT. We work together with the nuclear medicine staff, and they can provide us these because of the research purposes.
Thank you.
About safety, what are the most common adverse events when using these isotopes?
Okay, thank you so much. So when we use these isotopes, the patients say that they have fatigue, nausea, sometimes abdominal pain, and some discomfort because of the arterial access, and they can perform hyperbilirubinemia, liver dysfunction as a side effect mostly.